So I will take over now for chairing this session and start the discussion. I wish to thank first the three speakers. We had three nice examples of how to address these problems. I may start from the last one. I like the fact that it's been pointed out the importance of having a picture of what is going on and paying attention also on the social cultural situations of our patients and having some guidelines helping the healthcare workers to take care of these patients. But we had also two other beautiful talks about new drugs to prolong the survival of our patients. So now I would like to open the discussion, and if any of the attendees has a question for our speaker, please go ahead. Okay, so no question means that the lectures were clear, but still, I would like to invite our first speaker because we lost the conclusion. Unfortunately, his microphone was muted. So perhaps Dr. Gopal Kundu could make some comments and on these lectures, and perhaps can also add, if he wish, something on what he was saying, concluding a remark on his lecture, and then we move.
So thank you. So especially in India, that breast cancer is one of the major concerns. And so recently the government of India, through Department of Health and Indian Council of Medical Research, they are coming with a mega program, how to increase and enhance the survival, especially India-centric breast cancer patient. More specifically, stage 2 breast cancer patient, how to enhance their survival from 60% to 80-90%. So our major concern that we are now, whatever database we have across the country, northern part, southern part, east and west, we are trying to have a uniform healthcare system. We are also going to use artificial intelligence, AI, ML and DL, establishing some algorithm, and to have a national level database for the management of breast cancer patient. And that is the part of the program where I am also part of this collaborative program, where we are going to use the multiple approach. First of all, we like to see that, because here one of the issues, when we detect breast cancer, they are already in the stage 2. So we have to have a good strategic plan, how to detect breast cancer at stage 1 or prior to that. So if we can detect at the early stage, then either we can, through that neoadjuvant therapy or through that other therapy or surgery, we can control that if they reach stage 2 or beyond. So therefore, that our early stage of detection, and through this program, we are coming with a non-invasive detection system. And that also we have established by taking that serum from the patient or some biopsy sample, and we are making some PCR-based approach by analyzing that panel of genes with their specific variants, so that we can detect them at the early stage. Similarly, we are coming with a latest type of treatment, especially combination therapy along with immune therapy, in order to control this. Yeah, go ahead, over to you.
Okay, thanks very much for this comment, because what you were pointing out is also somehow connected with what Dr. Regina said about having a better picture of our patients and trying to address their needs and help with, you are saying, also with the help of artificial intelligence and whatever, but the goal is trying to figure out what are the needs around these patients. I would like to call for a brief comments before we go ahead with the second session, our other speaker, because he presented as these kind drugs to help in treating with as adjuvant therapies, which were mentioned now. So if Dr. Klaus Pors can perhaps give a comment on these, just to close this session, please, briefly. Is he here? Oh, yes. Okay,
I'm
thanks.
here.
Thanks.
Yes.
Thanks, Klaus. I really much, I was intrigued about those drugs. So if you please can tell us how you can envisage their usefulness in the next trials and next therapy to help somehow.
So I think you know, globally, I think we can all agree on that we are edging closer to better treatments. I think I was speaking to some clinicians. I'm actually in Italy at the moment. I was speaking to some clinicians about what sort of treatments we needed for colorectal cancer. And I think where there are lots of things that we can progress on. So in terms of the smarter sort of strategies, I think is, you know, whatever we give to patients, I think this is the general comment. Whatever we give to patients at high doses, we as humans, we don't like, because we are not naturally built for drugs. So whatever we give them, even if it's a very smart drug, it's not gonna be non-toxic. So we have to try and find so we have to try and find a way to manage the side effects as well as we can. But if we can reduce it, so in the UK, we have a breast cancer charity, for example, and their ambitious goal is that by 2050, their hope is that when we treat breast cancer patients, they can live well with the disease. So we're not necessarily talking about, can we really reach cures for all the different molecular subtypes? Could we get to a situation where, for example, you can think of, you know, people with diabetes or something, where you can self-administer the drugs and you can live well with diabetes? Can we get to that in cancer? If we can do that, we are in a very good situation. And I think that is probably where we can work towards. And I think some cancer types are more achievable than others. We can go to pancreatic cancer, where a very difficult task at the moment, even with the smartest type of therapy that you can think of, we are not quite there. So I think we are globally, there are great efforts by the pharmaceutical industry, biotech companies, academic drug discovery centers. I think we are making incremental efforts that are constantly improving on what we have. I think a space where I think there are going to be new opportunities is combining some smaller molecule therapies with immuno-oncology. I think that space we don't understand so well at the moment, because it's relatively new. But I've seen something preclinically where you can start maybe visualizing in the clinic how these can also improve. So I think it's it'll remain a challenge for us to develop these safe technologies so that we can treat, and the patient maybe can treat at home without having to go to the hospital and get IV for hours on end, and where maybe they don't feel as ill after the treatment. I think we're getting there, but we have a long way to go yet. I think it's probably a comment.
Thanks very much for this comment, because I fully agree. I think we need to change the philosophy in treating our patients now, because let me say, I think we've been in the last 15, 80 years treating the disease, not the patient. So we have been focusing on the cancer. We wanted to kill the cancer. Instead, we have to start curing the patient who can survive with the cancer. As you said, maybe it doesn't hold for all types of cancer, of course, and not at all stage. And of course, what was saying our colleague Gopal Kundu, we need to do early as possible this diagnosis, but then starting to treat the patient and treat the cancer as a chronic disease. This should be the philosophy, I think. So in this, I think putting together the 3 lectures are somehow giving hints to these directions. So I thank you all the speakers.